Hi, I'm Abigail Caudle from the University of Texas MD Anderson Cancer Center. Thank you so much for inviting me to be a part of this webinar. Today I'm going to talk about targeted axillary dissection and management of the axilla after neoadjuvant chemotherapy. Knowing the pathologic nodal status is one of the most useful aspects of multidisciplinary planning for breast cancer patients. It often helps us determine the need for chemotherapy. It can determine the need for post-mastectomy radiation, which alters reconstruction plans. So having that knowledge at the very beginning is vitally important. We know that physical exam alone has a very high false negative rate. However, ultrasound evaluation is much better, much more sensitive, and it allows us to biopsy lymph nodes so that we get pathologic confirmation of disease. In clinically node-positive patients, we often use neoadjuvant chemotherapy, and we know that 40 to 70% of those patients will convert to lymph node negative with chemotherapy. There's been a lot of interest in using sentinel node dissection to identify those patients who convert to lymph node negative. However, the use of sentinel node dissection alone is limited by a high false negative rate. What I mean by that with a false negative rate is the proportion of patients who would have had a negative sentinel node even though there was residual nodal disease present. So these patients, clinically node-positive patients, have historically all undergone axillary lymph node dissection, but we know that a lot of those patients do have long-standing morbidity after the surgery, including pain, limited range of motion, and the one we all worry about is lymphedema. Because of this, there's been a lot of interest in trying to identify a minimally invasive way to restage the axilla after chemotherapy, hoping that we could avoid a completion axillary lymph node dissection in those patients where chemotherapy had eradicated all nodal disease. So there are 3 published trials, the ACOZOG Z1071 from the US, Sentina from Europe, and SNFNAC from Canada, that all came out several years ago and really sparked some of these conversations. They all had very similar trial designs. They enrolled patients with node-positive breast cancer who went on to get neoadjuvant chemotherapy, and then those patients had a sentinel node dissection followed by axillary lymph node dissection so that we could compare the pathology of the sentinel nodes to the pathology of the other axillary lymph nodes to determine the false negative rate. What's amazing to me is that these 3 trials done in different parts of the country, different investigators, all had incredibly similar results. So when you look at the overall false negative rate in the 3 trials, they span from 12.6% in the 1071 trial to 14.2% in Sentina. So remarkably close endpoints. They also all showed that technique matters. So dual agent technique brought the false negative rate down by about 50% in all 3 trials, and removing more lymph nodes seemed to make it more accurate, but also using immunohistochemistry reduced that false negative rate. One of the things shown in the ACOZOG Z1071 trial is that there was a small subset of patients, about 170 patients, who had a clip placed in the lymph node at the time of biopsy. And when that clipped node was found as a sentinel node, the false negative rate dropped to 6.8%. Well, this makes sense. If you want to know if the chemotherapy has eradicated the cancer in the lymph nodes, you should look at the lymph node that you knew had cancer at the very beginning. Not surprisingly, when that clipped node, that biopsied node that we knew had cancer, was not found as a sentinel node, but was instead found in the rest of the axillary contents, the false negative rate rose to 20%. So that started us thinking at MD Anderson and led to some of the studies that we've done. The first is, what happens to that biopsied lymph node? Is it predictive of what's happening in the other lymph nodes? And then secondly, if it is there a way that we can identify that lymph node and selectively remove it? So we started with a registry trial. We basically asked our radiologists that when they did a lymph node biopsy and the patient was found to have nodal metastasis, that they place a clip in that lymph node. And then at the time of surgery, we did an axillary lymph node dissection on those patients, and we asked our pathologists to identify the lymph node with the clip in it and to report that pathology separately so that we could understand how the pathology of that node corresponded with the other nodes. And for this, I just want to make mention is that we only put a clip in one node, the one most suspicious node. Even if a patient had multiple suspicious nodes, they only clipped and biopsied one. So in our first published reports on this, we had 191 patients. 63% were node positive after chemotherapy. And when we looked at that clipped node alone, we had a false negative result in only 5 patients, which gave us a false negative rate of looking at the clipped node alone of 4.2%. Now, remember those 3 trials that we talked about. The ACOZOC Z1071 trial had actually set up a pre-specified success threshold of a false negative rate of 10%. So they were willing to accept a false negative rate of 10% in that trial. So you can imagine that we were pretty excited when we saw that the false negative rate of this one lymph node was actually 4.2%, so much lower. But we then wanted to know, does evaluation of that clip node improve staging over sentinel node alone? So in this population of patients, we had about 118 patients who had a sentinel node dissection and an axillary lymph node dissection performed. And so we could compare the pathology of the clipped node, the sentinel node, and the remaining axillary contents. And what we found is that in the 74 patients who were pathologically node positive, there was only 1 patient in which the clipped node and the sentinel nodes were both negative or gave a false negative result. So we found a false negative rate of sentinel node alone in this population of 10.1%, so very consistent with what the trials have shown. But if you added evaluation of the clipped node, it actually brought our false negative rate down to 1.4%. And why is that? Well, the clip node is not retrieved as a sentinel node in about 25% of cases. And we know that not only from our own data, but from data that's now coming out from all over the world. So if you're relying on evaluation of just the sentinel nodes after chemotherapy, you're missing the lymph node that you knew had cancer to begin with. So this is just a little summary of some of the results that have started to come out. But even when you go back to 1071, the clip node was definitely a sentinel node in 63% of the cases. It was definitely not a sentinel node in 20% of cases, and we don't know if it was or not in an additional 17%. So this was very exciting, but the next question is, can we selectively find that node and remove it at the time of surgery? And so that's how we began to look at targeted axillary dissection. So basically, when the lymph node is biopsied before the beginning of chemotherapy, we have our radiologist put a clip. And then at surgery, we had them mark that clipped node with a seed so that we could remove that in addition to the sentinel nodes. And the combination of removing the clipped node and the sentinel nodes we call targeted axillary dissection. This is just a picture. At the time we started doing this, we were beginning to localize breast lesions with radioactive seed. So that's what we used as we first started this new technique. And so the radioactive seed would be placed 1 to 5 days before surgery. That is a U.S. regulation. You can only leave radioactive seeds in for 5 days without a lot of regulatory burden. They would then go to surgery, and we would use the neoprobe to help us identify that clip node containing the clip and the radioactive seed. In our first publication on this, there were 85 patients, 50 were persistently node positive, and we only had 1 false negative result, which gave us a false negative rate of 2% for targeted axillary dissection. We're not the only one doing that. Here's some things that have been reported. However, I think there's several really exciting trials like CENTA, GANAI 3 that will be coming out, the RISES trial, that are really going to help us get a broader look at this technique in various settings. But what has been publicized so far, University of Pittsburgh used I-125 seeds, a very small group of patients in their first publication. In Spain, they're using the ELINA procedure where they use intraoperative ultrasound to find that clipped node. The Dutch group has been doing the MARI procedure, and so they actually put the I-125 seed in at the time of initial biopsy before neoadjuvant chemotherapy. As I mentioned before, we can't do that in the U.S. because of the radioactive precautions that we have, but certainly very interesting concept. In their first publication, they did not add sentinel node. However, they now have developed the RISAS, R-I-S-A-S, procedure in which they are adding sentinel node dissection at the time of surgery. And then there have been some reports from Stanford as well as in Korea looking at tattooing those biopsy nodes with a black carbon suspension. So we published our results and then wanted to know what everyone else was doing. So we did a survey of members of the American Society of Breast Surgeons, and we asked them what they were doing with some of these trial results and how they were incorporating them in practice. We wanted to know if they were familiar with the trial results, if they had incorporated them into practice. So were they offering sentinel node dissection to some patients? And if not, what was contributing to non-acceptance of the trial results? We found that 45% of surgeons said they offered sentinel lymph node dissection to at least some clinically node-positive patients before trials, compared to 85% after the trials. And then we asked them about technical factors they considered critical. 86% felt that dual tracer mapping was a critical part of this technique, but 82% said placing clips in the biopsy nodes and ensuring removal was also critical. About 2/3 were placing clips in biopsy nodes, and of that, 71% were localizing the clip node for removal. But this was a reflection of where we were at the time. Most people didn't have a great way of doing that. So a lot of surgeons were using wires, which we know can be problematic. The wires can move. It is more dangerous just because of the neurovascular structures in the axilla. There were a few people using radioactive seeds, probably just because of the regulatory burden it takes to actually have a radioactive seed program in the US. And then some were not localizing at all, but were confirming that they had removed the clip node with an X-ray. So where did we take that? Well, we said we believe that surgeons believe that placing clips and ensuring removal is important, but not everyone has a great way to do that. So we started exploring non-radioactive sources. About this time, we started using magnetic seeds, or the mag seeds, in the breast for breast localizations. This was our first registry trial as we started to work with this new technology. There were 107 patients, had 124 mag seeds placed to localize breast lesions. You can see a little bit about those breast lesions. There was a 100% surgical retrieval rate, a median operative time of 15 minutes with no adverse events, and a positive margin rate of 7.5%, which is equivalent to what we've reported in the past with both wire localization and seed localization. So we started to explore the possibility of using mag seed in the axilla. Here's just some pictures of that's the 2-mark clip. That's the kind of clip that we tend to use in axillary nodes, as well as the mag seed. And so we established a prospective registry trial. We enrolled patients anytime before surgery. They had to have a clip placed at the time of nodal biopsy, receive neoadjuvant chemotherapy. They then had a mag seed placed in that clipped node, and at surgery they had a targeted axillary dissection. So we removed the clip node and the sentinel nodes. We recommended dual tracer technique, and we asked that surgeons remove that clip node first so that we could be sure that they could localize it using the Sentimag probe. Our primary endpoint was the clip and seed removed in the same specimen. So we had 50 evaluable patients. This is just a little bit of what they look like, very typical of what we see in our breast clinics. We had 17 different radiologists place the mag seeds. It took a mean of 6.1 minutes, so easy to place. You can see the size of clip node on that last ultrasound after chemotherapy was about 1.5 centimeters, even though some of them were even smaller than that. And our radiologists were able to identify it and get the mag seed in the node. 100% of cases, the mag seed was placed on the first attempt. And then we had them judge where it was. So 88% were within the node. A few were in the cortex or very close to the cortex. And then one case had the seed placed by the clip because they couldn't see the node very well. At the time of surgery, the number of nodes retrieved with a mag seed specimen, so evaluating how precise this allowed us to be so that we could identify really just one lymph node. And you can see our mean number of nodes retrieved was 1.3. In 98% of the cases, the seed and the clip were in the same specimen. That was our primary endpoint. The seed stayed within the node for retrieval in 100% of cases. If some of you have used radioactive seeds in the past, especially in the breast, sometimes they tend to slip around as they're manipulated in surgery, but we were happy to report that the mag seed stayed within the node during the manipulation of surgery. The clip node was a sentinel node in 80% of cases. We then asked surgeons how easy was it. You can see the vast majority felt like it was easy or very easy. There were a few surgeons that report difficult transcutaneous localization or intraoperative localization, but I should tell you that those surgeons later through the trial then reported easy localization. So I think this just shows there's sometimes a little bit of a learning curve, but there were no device-related adverse events. The adverse events that we had were cellulitis of the contralateral breast and the ipsilateral breast, some superficial phlebitis, a chloroprep reaction, nothing related to the magnetic seeds. This has then established the ground for our new trial that we're currently enrolling patients on called Magellan. So MagSeed-enabled long-term localization of axillary lymph nodes. And here's the trial schema. We actually have a MagSeed placed in that clipped node before they start chemotherapy. They get neoadjuvant chemotherapy. They have an ultrasound at the end to be sure that that MagSeed is still in this node. And then they go on to have targeted axillary dissection. I can tell you that we're still pretty early into this trial, but so far there have been no technical issues. The MagSeed has stayed within the node, easy to get out at this time of surgery. We think there's several advantages to this. One is that it would allow our patients to have one less procedure, because what we would like to do is put a MagSeed in that node at the time of biopsy instead of a clip. Two, I think that it'll make targeted axillary dissection a little bit more generalizable. As many of you are aware, one of the complaints has been that either the radiologist can't see the clip at the end of chemotherapy, or that node, which is now small and fibrotic, is really difficult to get a seed in or some sort of localization device. By putting that localization device in at the very beginning when the node is soft and large, we think that's going to help with the technical issues that people have had. It also, because it is very easy to see on ultrasound, it really allows for visualization through chemotherapy. So in conclusion, targeted axillary dissection improves axillary staging after chemotherapy compared to sentinel node alone. There are several European trials enrolling or who have completed enroll that we're really excited about hearing all the results. So CENTA, GANAI 3, RISIS. I know CENTA has already started to publish some of their results. Magnetic seeds allow for targeted axillary dissection without risk and burden of radioactivity. And there's potential for them as the definitive axillary node marker. I want to thank you for allowing me to participate, even virtually. Hopefully we'll all be together soon in the future.